Hello, thank you for the kind invitation. So the topic is early detection of pH in ILDs and some novel algorithms. So to get things started, all we know that pH in the setting of ILD could be group 1, group 3, or group 5. Group 1 in the setting of CDD-ILD, typical example scleroderma. Group 3, the majority of ILDs. Group 5, some ILDs that have systemic component. And it's important also to know that group 3, which represent most of the patients with ILDs, has the worst outcomes. You can see here in this table, 72% survival 1 year, 5-year survival only 37%, and that's a very good response to the question, why is it important to know the presence of concomitant pulmonary hypertension in the setting of interstitial lung disease? Do we need to know? Yes, because there are prognostic and therapeutic implications. You can see from this paper that patients with ILD and concomitant pulmonary hypertension, red demarcation, have worse survival, and several markers of pulmonary hypertension like 6-minute walking test, TAPSE to PASP, SVO2 or PAC, pulmonary artery compliance, with blue demarcation, the high-risk group, have worse survival. And this is also another interesting paper showing that in case of fibrotic ILD, if you have concomitant pH, pH is the one that drives mortality and not the ILD. So even if in the absence of IPF, prognosis is still very poor. So in terms of therapeutic implications, do we need to know if we have pH? Yes, because we have drugs. You know the INCREASE trial some years ago. As you can see in the graph, unfortunately in the graph there is a wide demarcation both for the treprostinil arm and for the placebo arm. I'm kidding. You can see with orange demarcation the treprostinil arm and with blue placebo. Treprostinil increases walking distance in 6-minute walking test, and this fueled the recently published TETON trial showing that treprostinil has a beneficial effect in terms of FVC in patients with IPF. I would like to mention that in this study, in the TETON study, there was no exclusion of pH with right heart cath. So we don't know the proportion of patients that had pH in this group. Maybe we need another study purely in IPF without concomitant pH to understand the truly antifibrotic effect of Tyvaso. But anyway, the data that we have right now are these. So we have drug Tyvaso both in DPI and as nebulizer for concomitant pH. So it is important to know if we have concomitant pH. But the truth is that in the real world, in the clinical practice, in several countries, pulmonary hypertension is an under-recognized complication of patients with IPF. So we need to start increasing the awareness when to suspect pH in the setting of ILD. First of all, when we examine the patient, we need to be aware of the fact that ILD patients in the beginning have some symptoms like cough, fatigue, dyspnea, but as they experience disease progression, some other symptoms might be obvious, like dizziness, which is a key symptom for pulmonary hypertension. And we need, in every visit, to ask the patient, do you have unexplained shortness of breath? Do you experience any change? How is your exercise capacity and history of syncope, peripheral edemas, meticulous evaluation for murmurs, third heart sound, venous distension, or parasternal heave. And also, we need to meticulously evaluate the functional domain, the biologic domain, and the radiographic domain. In terms of functional markers, we need to evaluate DLCO and KCO, especially if there is a marginal drop. We need to see if there is a disproportionate decrease in DLCO compared to FVC. We need to have 6-minute walking test in these patients, and not only 6-minute walking test, but also heart rate recovery. And this is something that we are not doing that much in Europe. In USA, almost every patient has a heart rate recovery because it's very simple. You wait 1 more minute after the 6-minute and you measure again the beats per minute. I would like to say that 6 minutes gives us information about blood gas exchange, muscle function, maybe cardiac output, but HRR can also tell us about persistent sympathetic activation, impaired chronotropic competence, or reduced stroke volume capacity. So we need to take these parameters into consideration, and if we have availability of CPET, that would be great also. Limitations, reproducibility of DLCO, for example, confounding factors like thyroid disorders and anemia. In terms of the biologic domain, BNP is the best that we have in clinical practice right now, but it's not a disease-specific biomarker. Left heart pathology can affect, renal dysfunction can affect, coronary syndrome, obesity, all these can be confounding factors. And also we need to meticulously evaluate CT scan as we have more and more data that increased PA to aorta ratio, increased pulmonary artery, peripheral vessels are all markers of pulmonary hypertension. Again, here we need to meticulously evaluate the parenchyma for the underlying CTD because some CTDs are associated with disproportionate pH, and also we need to exclude PE or diseases like PVOD. But none of these markers are ideal. We knew it several years ago, so we need composite scores, not only one biomarker. And there have been tremendous efforts in the last year to create multi-parametric prediction models for pH in the setting of ILD. I'm going to present some of them, but it's important that you take a look here. Most of the groups have CT scan parameters like pulmonary artery diameter, FVC to DLCO, 6-minute walking test, history of syncope. Some have cardiographic parameters, cardiac echo, TAPSE. And let's move on to some of these models. One of these is the model by Stephen Nathan and colleagues, so-called Ford model. So these authors analyzed the data from Artemis IPF, and they found 4 predictors of pH, FVC to DLCO, oxygenation, race, and distance. F for FVC, O for oxygenation, R for race, D for distance, Ford model. And as you can see, these are the points. The maximum score is 100. And for example, if you have FVC to DLCO 2.5, you get 2 points. If you walk 270 meters, you get 9 points, and this adds up, and you can have a total of 100. The higher, the worse. But there is a problem with this algorithm, at least in my perspective, that only 10% in the Artemis study had concomitant pH. And we have here experts in statistics like Professor Janakis. So if we have a group that only 10% has the event and is not balanced, is not the ideal population to have the optimal sensitivity and specificity. Imagine that you have a population that 100% of the patients had pH. Then sensitivity would have been great, but this would have been a mistaken message from the data. But anyway, this is the Ford model that led to AUC of 75. And as you can see here, for example, a score of 29 is the ideal cutoff threshold based on the Uden analysis. But the optimal sensitivity, which is the one we care in terms of pulmonary hypertension, because we need to detect pH, is even with a score of 3, sensitivity 87%. So even if you have increased FVC to DLCO, or you don't walk that much in the 6-minute walking test, this model refers you to right heart cath. But again, that's the problem, that only 10% of this population had concomitant pH. So these data are not the ideal to create a model. Maybe we need a more balanced population that's like close to 50-50 pH, no pH. And this fueled more recent studies like the Finder study. We don't have the final data yet, but we have some preliminary analysis. And please take a look in the middle with colors. You can see red demarcation. 56% of the patients in idiopathic interstitial pneumonias, almost 25% CTD ILDs, and then some patients HP, NSIP, other diseases. As you can see from the graphs, this is closer to 50-50, so it's better to analyze the data in terms of statistics. And the preliminary analysis shows, as you can see to your right, that Supplemental oxygen use, low DLCO, TAPSE to RVSP, TRV, RV to LV diameter, PA to aorta ratio are predictors of pH in this group. But also these studies also showed us something really important, that clinical suspicion is not that great. As you can see to your left, here are the patients with high clinical suspicion of pH before any procedure. And as you can see, that 31% of the patients that the clinician suspected pH finally didn't have pH, while on the contrary, 32% here that the clinician said low probability of pH, in the end of the day, had right heart cath confirmed pH. However, the data from a Finder study are not final. We are waiting the final analysis. And now I would like to show you our algorithm. This is an effort that we did in University of South Florida, Cleveland Clinic, and Soteria Chest Hospital with patients that underwent right heart cath for suspected pH. These are patients with ILD. Some of them in the end of the day had pH, some of them in the end of the day didn't have pH. So we compare the features of patients that had pH versus those that didn't have pH. And as you can see in this forest plot, these were the parameters that were significantly associated with pH. It is gender, heart rate recovery. Again, heart rate recovery gives us more information than 6-minute walking test alone. It can tell us about chronotropic competence, sympathetic activation, etc. 6-minute walking distance was independent predictor, BNP, PA to aorta ratio, main pulmonary artery diameter, and RVSP. And what we did is we took the odds ratios and we rounded the values. And based on the odds ratios we had, we created a score with a maximum of 25, and we named the score FOS, from pulmonary hypertension optimal screening. As you know, FOS in Greek means light, so this is an effort to set light in terms of pH detection. And this score, following ROC more than 14, has an 80% sensitivity and AUC of 78 for the detection of pH. And you can see in independent cohorts that there is a positive correlation of FOS ILD with MPAP, University of South Florida, Cleveland Clinic, and with PVR, which is a surrogate of mortality in these patients. Now, specifically in the setting of scleroderma, we also have DETECT. And DETECT is very easy to use. You can see here that there is an app also that you can put the data and you can have the score. So in the first step in the DETECT, you put FVC to DLCO predicted, history of telangiectasis, presence or absence of anti-centromere antibodies, BNP, U rate, and right axis deviation on ECG. And if you have more than 300 points, then you need to evaluate right atrium area and tear velocity. And if you get more than 35 points, you refer the patients for right heart cath. And DETECT algorithm had only 4% rate of missed PAH diagnosis. So it is a clinically applicable algorithm with very fruitful outcomes. And following the algorithm, I would like to show you a case to highlight the importance of evaluation of the CT scan and pH in these patients. This is a patient that was referred to our department like 7 months ago. The patient is a 77-year-old male that was receiving nintedanib. For like 2 years, he has experienced 2 myocardial infarctions. And when we met him, the patient had 5 liters oxygen therapy as baseline. And the first question that came to our mind is this CT scan alone able to explain this functional status of the patient? By the way, the patient has had 87% FVC, 29 DLCO, RVSP of 50, and T-proBNP more than 1,000. We are doing MDD for ILDs in our department the first Tuesday of every month. This is a case we discussed, and we have the pleasure that my professors from USA are joining. Dr. Bundy was one of the main authors in the Teton trial in New England. He used to be my mentor in PH-ILD, and he's still present in our MDDs. So we said we need to explore pulmonary hypertension. We did right heart cath. As you can see, MPAP 50, PVR 14, again PVR 14, PCWP 7. And pretty much this is what we implement in the clinical practice. We have data for treprostinil, so every patient with IPF and concomitant PH is receiving treprostinil in our center. But based on the data that we have right now that are kind of neutral for sildenafil, in case of disproportionate pH with PVR more than 5, we also implement sildenafil. And as you can see, after 3 months of treatment, this patient had a marginal reduction in MPAP, more than, not more, 15 millimeters of mercury, and 50% drop in PVR, and the patient now is in room air and not in 5 liters. So I would like to thank you for your attention. And I would like to mention that the first Tuesday of every month we are doing the MDD in ILDs, and we also discuss cases of PH. And we have also availability through Zoom, so anyone who can serve you is welcome to join. Thank you.